Good afternoon. Thank you all for joining us today for the October Romano rounds. I'm Sue DiGiovanni. I am the Vice Chair for Clinical Services, and it is my pleasure to introduce our presenter today, Dr. Kayla Hunt. Dr. Hunt is a child psychologist in our department. She received her doctorate degree at Roosevelt University in Chicago, and she originally came to us for her pre-doctoral internship in the child and adolescent track here in 2015, and then remained for 2 more years, luckily for us, for her postdoctoral fellowship, and then joined us on faculty in August of 2018. As you will hear, she wears multiple hats in our department. Not only does she provide direct clinical care within the child and adolescent outpatient clinic, but she also supervises trainees and staff, and also serves as the lead psychologist in the behavioral health service within the outpatient neurology, child neurology clinic. In addition, she has leadership roles within our department. She is the Associate Director for Pediatric Behavioral Health and Wellness in our Child Outpatient Services, and she also serves as the Associate Director of Informatics for our department. And it is in that role that she presents today on the EPIC Behavioral Health module, and as you can see, it's going to be EPIC, and it is coming soon. So thank you very much for sharing your knowledge and giving us a heads up about what we can expect. Thank you.
Well, thank you very much, Dr. DiGiovanni, for that introduction. As she mentioned, I'm going to be talking about the behavioral health module, which I do think will be epic. You know, the title, I think, truly says it. So I'm going to talk a little bit more about that today. In terms of just general information, I'll talk about learning objectives again in a couple of slides. No financial relationships, and we have our accreditation statement. So as Dr. DiGiovanni mentioned, I am a child psychologist by training, and that's the majority of my clinical work that I do is currently in the Pediatric Behavioral Health and Wellness Outpatient Service. I came here in 2015. Didn't think I would be here long, but alas, here I am still 8 years later, and very excited about that. I began as faculty in 2018, and really once I got here, I was very interested in eRecord, really interested in learning more about how we can make it better for clinicians, better for patients, really focusing on just how to optimize it overall. And I was doing a little bit more of that directly in the outpatient service, and then over the years that got noticed by leadership in the department, and then that resulted in an appointment in 2021 to Associate Director of Informatics for Psychiatry. So I'll talk a little bit about that, what that role entails, because it's a new one. So that role really has 2 functions. One is within the Department of Psychiatry. So I have a small team, and we meet with clinicians, other leaders within the department, to figure out how we can optimize eRecord to make it better, again, for both clinicians and patients. And then we also look at how to pull data out of the medical record better, which is an ever evolving problem. And then the second piece of that is more at the institution level. So I attend meetings with informaticists throughout the institution and help disseminate information that is coming from the institution level back to psychiatry. So I have those 2 roles as an informaticist within psychiatry. As a part of that, I completed clinician builder training at EPIC in 2021 as well. And that really helped me do more of a deep dive into what are the possibilities within EPIC, and allowed me to do more of the behind the scenes building myself. So became more of an expert in EPIC specifically. And then as we were planning to do the launch of the behavioral health module at the beginning of this year, I really was identified as the lead clinical informaticist for that project. And so that's been the majority of my 2023. So in many ways, I am very excited to stand before you all today to talk about this, because it's been a long time coming in my mind. And I have a few objectives of the presentation that I want to make sure we get to. So the first one that you'll see is to help reduce overall anxiety about this module. I know this is something that I've heard about for at least 2 years, but as this very kind of amorphous thing that's coming. Some people think it's going to be a very big thing. Other people have no idea that it's happening. So for those who've heard a lot about it, I'm hoping that after today's presentation, there will be a little bit of a sigh of relief to understand that the changes will be significant, but probably not as expansive as you may have thought prior to this. Also, just to have increased awareness of what's going to come, I find as a psychologist often reduces anxiety. The second objective is to provide a really broad overview of the changes that are coming with the module. There will be a lot more information and training in the next month before the launch of the module, but this is really just a snapshot to give people a sense of what's to come, again, because I know there hasn't been a ton of detailed information thus far. And then I'm going to talk about some of the advantages to using the functionality that comes with the module, because obviously we're doing this for a reason, and there are a lot of benefits that come as a result of making these changes. So I'm going to highlight those as well. So I'll start with, just some general information about what is the behavioral health module. And module is a term that EPIC uses to describe a group of new functions or upgrades that will be available in EPIC. So EPIC kind of comes as a main bundle, and then they have these different modules, and the behavioral health one is one that they've created more recently, and that we decided as a department to purchase. Like I said, it's going to launch on November 12th, and the primary functions are related to treatment plans and episode of care, group documentation, and safety checks, which are on the inpatient and CPAP units only. And I'll clarify that when I'm talking about inpatient, I'm talking about all the psychiatry units, so that does not include like G92 and 192. So for the rest of the presentation, know that when I reference inpatient, it's the psychiatry units that I'm talking about. And if I had to divvy these three up, I would say that 90% of the changes are related to treatment plans and episode of care, and that's across settings. About 5% is group documentation, and then 5% for safety checks. So it's really heavy on the episodes of care and treatment planning changes. There will be absolutely no changes to intake notes, progress notes, discharge summaries, your in-basket, how you do phone notes, all of those other things. I didn't hear too many sighs. Thank you, Segundo, for that clap. So I hope really that more specific description is a positive one for people to know that while the changes for the treatment plans are significant, there's a lot of your day-to-day stuff that is not going to change. So I mentioned that there will be more training beyond just my grand rounds today. An e-learning will be available on Friday, October 27th, and that will go out to all necessary staff. And we've kind of gone through and identified who will need that training and what training they'll need. And that gives us about 2 weeks before the module launch. And so that e-learning is coming from our centralized e-record training group. It's going to involve approximately 45 minutes of training, which is mostly watching demonstration videos, but there's also going to be a playground available, which is essentially a fake EPIC setup. And anyone can go in and practice using the new functionality. The training team will come up with what they call assignments that really have step-by-step directions on how to do a treatment plan using the module. We are strongly encouraging that all relevant staff complete the training ahead of the launch. There's nothing in the way of you won't get locked out of e-record if you don't complete the training. Contrary to like when you first start, you can't log in until you complete certain trainings. So just know that this is really very, very necessary for a lot of your clinical functioning. So we're just saying that you definitely should do the training. All right, so the next part of my presentation are some broad overview demonstrations. And I really want to obviously emphasize that word broad because there are going to be a lot of questions that come with this. And again, my focus for this is really to just give people more of an idea of what this is going to look like and know that you are going to get much more information with the e-learning materials that come out in October and late this month. Additionally, every clinical area is going to have more specific instructions on how the treatment plan should be filled out. So please refer any of those questions to your clinical leaders. There will be no changes related to regulations regarding like the deadlines of treatment plans or who has to sign treatment plans. So also keep that in mind, that whoever's been co-signing now or how long you've extended the deadline for the treatment plan, all of that will remain the same. So I'm going to demonstrate how to open an episode of care and do a treatment plan with our new behavioral health module. So the first thing I'm going to do is open a documentation only encounter, which is the same process as you do for a treatment plan now. And I'm going to be doing this in the adult ambulatory Chestnut department. So when I open a new encounter, I'm going to go to episodes of care and I'll add a new episode. And I'm just going to name this the same as what my department name is. And then some of you might see one or more options here, and some of you just might see one option. But I know that this is for adult outpatient, so that's the episode type that I'm going to select. And then one important thing to make sure to do when you open your episode is to associate a problem from the problem list. So you may have options here to select from, but you might have to go to the problem list and put in a problem. And Patrick here has generalized anxiety disorder. And so we're going to select that and then go back to the episode. And you can see that I am now able to link it and I make it the primary and associated diagnosis for this episode. The second thing I'm going to do is go to the forms and add the department and care team. So the managing department is the department where the patient is being seen. I'm going to add myself onto the care team. And then I'm also going to add Patrick's psychiatrist. And I would add anyone else who is providing care, like it might be whoever is the group leader, if they're in group, or if they're getting family therapy. So whoever's giving services within this department. So that's all you have to do for the episode. And then you go to the treatment plan tab, which you might have to wrench in. And the first screen you're going to come to is this manage plan and document progress section. And you're going to add a care plan. So you can either click on this link here or add a care plan from here. And when you search for care plans, the ones in bold are the ones that are going to come up for your login department. So this might look different depending on what department you're in. I would encourage people to look through the different options as you're getting familiar with it, because obviously they're organized by diagnosis, but there might be some that you find helpful in other sections. So I'm going to add the anxiety care plan and pick a couple of goals that apply for him. And then I'm also going to pick some interventions that are appropriate for those goals. And then press accept. And so once I've accepted those goals and interventions, they'll show up in my care plan. And you'll see that there are pencils next to a lot of these sections. So really this is organized by saying that this is the main problem, these are the goals, and these are the interventions. So I could change this to say generalized anxiety disorder if I wanted to make it more specific, or I could leave it as it is. And when I change that, you'll see it's changed there. And I'm going to say that Patrick needs to attend 90% of scheduled sessions. So anything that has a pencil next to it, you can edit. And the other piece that needs to be added here are the end dates. So the easiest way to do this is to put the end date up at the top. And for outpatient, we do treatment plans for a year. So I'm going to apply this to all goals. And you can see that these are now added here. And you'll also see if I expand this that you can add a description. So I'll just put in something here so we can see what this looks like. But we are not requiring any terms of any kind of priority or frequency as in the care plan. So once I am done with my care plan, I'm going to click the next button down at the bottom. And that actually takes me to the next tab, which is the plans tab. And I'm going to start a new plan. And there are sections that are called print groups. And you can see that it pulls in the patient demographics, patient contacts if those are entered into the chart. And then there are different sections where I need to add notes. It pulls in our associated problem from the problem list. And then finally, you can see that it pulls in that care plan that I just added. And it has the changes that I made in terms of calling it generalized anxiety disorder. And we have that test description piece here, and it has the start and end dates for all goals. So I'm going to go through and create each of these notes. And I can see that it's required because I have this hard stop sign right here. So when I bring up create note, for most of the ambulatory settings, there will be a smart text or a wildcard in here indicating what you have to complete. So I know that we are going to have Patrick do the GAD-7 in terms of monitoring progress in treatment. And he was present and available to complete the screenings. But I see that I have not entered the data that I got on a paper form of the GAD-7. So I'm going to click on this link, which pulls up the flow sheet. I'm going to enter in his responses and then press accept and refresh my note. So it pulls in the score. And then I don't need to add anything additional. So when I accept this note, you can see on the left-hand side here, it automatically updates this information. Then I need to add the discharge criteria. So for adult ambulatory, they've selected to make this a wild card. So for discharge, Patrick will show decreased GAD-7 scores, improved functioning, and increased involvement in family activities. I'm going to press accept. That again gets pulled into this left-hand side. Treatment modalities is a section we've had in the outpatient treatment plans thus far. So I need to indicate what services he's receiving in this clinic. So I said that he's getting individual therapy from me and psychopharmacology from Dr. Fu. So I enter in this information, and some of this information is going to come from guidelines from your specific clinical area. So always make sure to ask your clinic leaders clarification about what should be put in these sections. And then I press accept. And again, it pulls in on the left-hand side. And then we always need to add strengths and challenges. And this actually pulls in the flow sheet link from the section of the flow sheet that we've been entering in for our current treatment plans. Just add this because I realized I forgot to do it. And I can add it here and then refresh the note to make sure that that gets pulled in on the left-hand side after I press accept. So now I can see all of these notes are filled out as they should be. The next thing I need to do is make sure that I put in the effective from and to date. So it's automatically going to pull in today as the effective from date. And then I'm going to do that year from now, date for effective to. And then you'll notice that it automatically pulls in a few different participants. So it pulls in the patient as a contributor. It pulls in myself as the owner because I'm the one who created the plan, and it has me as the person who must sign. And then it pulls in Dr. Fu because I put her in the episode of care. And I think that she also must sign because she is providing care for Patrick. Even if you don't mark them as must sign, they're still given the option to sign. So there are other participants that we might want to add. We might want to add patient contacts in terms of, I believe this is Patrick's wife. We could add that person as a contributor. We could also add a supervisor. So if you need a supervisor to sign off on your treatment plans, you can add them as a provider, and you would probably select them to be a reviewer, but they still must sign. And once I've added all of my participants, I can mark everyone as contributed because I know I've added all of the components that are necessary for each person in this plan. And then when I click finalize, you'll see that the treatment plan shows up in a bit of a nicer format, but has all of the components that I had showed on the left-hand side, including that care plan that we did in the last tab. And on the right-hand side here, if I have the patient in the room with me, I can select sign and it'll pull up my signature pad. If I'm doing this as a remote Zoom, I can say that, mark them as signed and say that treatment plan was reviewed over Zoom. I can sign myself. And then I will also show how it looks in terms of how you will know that you need to sign a treatment plan in your in-basket, because it'll look a little bit different. So I will show that now, even though I already signed for this one. You can see that if I go to chart completion, that's the section where it would come up as bold if I hadn't already signed for this patient. But this one, you can see that a signature is needed, and I can visually review the entire care plan for this patient, care plan and treatment plan. And I can sign right from here. Or if I had double clicked on this note, I might have to reopen the encounter. It'll bring it up this way, and I can sign by clicking this button. Going back to my original treatment plan, I'm just going to mark everyone as signed so we can move through. If I did need to edit this in any way, there is a button down here to create an addendum. And if I click on this, you'll be notified that this will clear all signatures. But if you do need to make an edit, you can come in and you can see I can edit each individual note, or I can go back in and edit the care plan. And then the updates will go into the plan here. And just a reminder, on this upper right-hand corner is a refresh button, if I would ever need to use that to refresh any different section in the treatment plan. So another important piece to be aware of is where to find a completed treatment plan. I go into chart review for Patrick. You can see that if I click on the plan of care documentation, I can see the formatted version of the treatment plan here, and I could print this just like I could print any note. But if I go to the episodes section, I can also see my active episode in adult ambulatory. And if I go down to current plans, I can see his current outpatient treatment plan. I can see effective from and effective to. And that will also bring up this formatting. And if I click on view original plan, I can even get it in a PDF. And this could be something that you save and then send to either the patient or other providers outside our system. And then if I go back actually into, if I addend my original encounter for this treatment plan, one other thing to know is that if I want to share the plan from here, I could pick original or patient facing. Patient facing just has a little bit of the information unavailable, like the contact information for each of the providers. But other than that, it's not much different. But what I can do is I can create a letter from this, and this letter will then be sent. I can send it to the patient, or I can send it to anyone else in the same way that you can send a letter outside of our system. Next, we're going to go through the inpatient plan.
Inpatient treatment plan, care plan example. The biggest difference here is that after November 12th, any patients will be automatically assigned an episode of care at admission. So that's not something that you have to create automatically. And so I'm going to go through this as if I am an inpatient provider. So I would go to the treatment plan tab and add a care plan. And I'm going to search using the term PHIP. And you can see there are different options here. I'm going to choose the inpatient depression option and select a few short-term or a few goals and interventions. And you'll see that those come up. And so one thing you'll see in this example that I didn't show in the outpatient example is that there are wildcards that need to be completed in here. So I get this alert up here to let me know about this. And if I go to next invalid name, then I can fill out any of the wildcards that need to be completed. I will put the expected end date, apply that to all of my goals. But again, it looks very similar in terms of being able to see the goals and interventions and being able to write any descriptions in the description section. And then I will click and I will start a new plan. You can see it says PHIP treatment plan and brings in the patient demographics. And then I have different sections that need to be filled out here. And a lot of these sections are actually pulling from the flow sheets tab. And so all of the different disciplines, like the activities therapist, mental health therapist, will have entered in their flow sheet information already. And you can see that's all pulling in, but if I wanted to go to it, I could click on it and see what the last fill value was. And then I could also enter in anything that needs to be entered. And it's a good reminder to make sure that that's all completed. There are a few sections that are currently in this demo that will be changed. So that might be a bit of a difference that you see once this goes live, but we have our problem this is from the problem list that was linked to the episode. And then you can see we have our care plan. And then the effective date is for the next 7 days. And then here is where you would add different providers that are a part of this patient's treatment plan on the inpatient unit. You can see that I come up as a provider here and I'm the owner and I must sign, and the patient is listed on here as well. Your different inpatient units will have guidance on who should be added to the contributor list and whether or not they must sign. So please ask your clinic leaders about that. I'm just going to mark all as contributed and then do the same thing on finalize. And I can see that all of this information has pulled in from the flow sheet. And then I can sign myself and I can mark the patient as signed too.
All right, so the thing that I will call out specific to the inpatient treatment plan is that the care plan probably looks very familiar for many people because nursing staff have been using a care plan for quite some time now. And so there will be no changes to the nursing workflow and the nursing care plan, and that will pull into the treatment plan just like now the inpatient behavioral health care plan will pull in. So you'll essentially have both care plans pulling into that treatment plan document. And one thing I did mention in both videos, but I want to reiterate, is that the view for some pieces of this is going to be different depending on what login department you're in. So for example, there were different options in terms of what could have been chosen for what shows up for the care plan options in that list. And some departments chose to use what Epic had recommended, and some chose to build their own. So just be aware that that's a place where you might see things a little bit different. And then in that outpatient treatment plan 2, each of the note sections, the smart text that pulls in, will likely look different depending on your clinical area. So just be aware that you might see things a little bit different than what the demos you saw today, or some of the demos you might see in the e-learning modules. So a question that probably comes up after seeing those demos is how are we going to move to this? What's the plan? And I'm going to give a brief overview, but there will be more guidance from your specific clinical areas about how this is going to work. I demonstrated 2 completely new patients that didn't have existing treatment plans, so you will get guidance about how to transition from an existing plan to a new plan. So know that that's coming. But across services, any new patient admitted to that service after November 12th will have the new treatment plan and new episode of care using the module workflow. So that's consistent. For inpatient, the guidelines are that existing patients will continue to have that legacy treatment plan unless they're still on the unit by Monday, November 27th. And at that time, they'll transition over to the new workflow. So we know that generally inpatient turnover is pretty quick. So a lot of those patients who are on the unit on November 12th will just keep with their same treatment planning. But if we have some who are kind of having an extended stay past the 27th, that's when we'll transfer them over to the new workflow. For the partial hospitalization programs, existing patients will continue to have the legacy treatment plan until discharge. Their length of stay is usually about 3 weeks, so there will be a 3-week span of time where some will have old and some will have new, but the turnover will eventually result in everyone having the new plan. And then across our outpatient clinics, clinicians and providers will have until the end of December to transfer over their entire caseload to the new treatment plan and episode of care workflow. And again, there will be more information about time that will be allotted to people to do this work, because we know some of you have caseloads of up to 50 to 75 people, and so that's going to be quite a bit of time. So we acknowledge that and are going to have a plan that will be discussed about time that will be blocked to allow for that. And we know that it's going to take a little bit of time to get used to it too, so that's why we allowed until the end of December to fully transfer over caseloads. All right. The next piece, again, one of the more minor parts of the module that I want to talk about is group documentation. So for all ambulatory clinics, anyone running group therapy will start using this new workflow. Sometime in November, each clinic has kind of different guidelines about when they're going to start this and what it's going to look like. When building the new workflow, we used many of the same note templates that you're already using to write your group notes, so hopefully it'll look very similar. I have a brief demo video on the next slide. There will be a few areas on the inpatient units that will pilot use of this group documentation workflow, and we may decide to expand the rollout in the future depending on how that goes. But the vast majority of the current groups will not be using the group documentation workflow at launch. And one thing to know is that the partial hospitalization programs have already been using this workflow for over a year, and they really like it. I think it's a lot more streamlined than what they used to do.
I'm about to review what it looks like to document a group using the group documentation function in the behavioral health module. So you can see I have my 4 patients who are scheduled for my 4 o'clock group. And the way that you start group documentation after the patients have arrived is to click on this document group button in the top right. It might be under your more tab after we go live. And when I click on this, you can see I can enter a few things. So the start and end time for the group. And if I just put the number and then press tab, it rounds to the hours. This is going to be an hour-long group. And then I can select the topic. So this is our older adult DBT group. And it's in older adult department, and I will create. And then you can see my 4 patients on the left-hand side come up. And I know that all 4 of these patients attended, so I'm going to add all. If for some reason I needed to remove one of them, I could just select the X. And then I have myself as a facilitator, and I also have Tyler co-facilitating with me. And you see below that there's a template that pulls in related to the group note, and this is a note that will go into all 4 of these patients' chart. So this is only a part of the note for now, and I'm going to F2 to talk about the group that we went through and the group ID. And then once that is done, I'm going to press continue. And what pops up is the first patient that I have for this group. And so you can see that a few things pulled in from what I entered on the last page. So the start and stop time, it pulled in how many participants were in the group, the leaders, and then what I had entered in terms of the group title and the group ID. This big. And so I can do F2 to move through each of these sections. And this is specific to this patient that I'm in today. And then once I am done with this note, I can press accept. And then you'll see it prompts me to ask or to put in the visit diagnosis. And then I will put in the charge like I normally do. And then you can see there's an option to say sign and next. Or I could just sign the visit and leave these ones open. But if I press sign and next, it will take me to the next patient in my list. And again, you will see that it brings in that group level documentation, and then I can make specific changes for this specific patient. But let's say I had to leave the notes and come back to this later. If I X out and then go into my in basket, you'll see that there are 3 incomplete notes for the patients that I did not get to.
And one thing I'll say about group documentation for inpatient is that it looks identical to that, but instead of selecting patients from the schedule, you would select patient from the patient list and you wouldn't drop a charge. So those are really the only differences. And when the e-learning comes out, I know many outpatient groups are run by multiple facilitators, so there will be more information about how you would divvy up the group notes between facilitators. All right, and then the last piece that comes with the module are safety checks. And like I said, this will be for inpatient units and CPAP. And right now those are currently being done on paper. Starting November 14th, these will move to the Rover app. And my understanding is that the Rover app is already being used on all of the units. So hopefully that won't be too much of a change. We decided November 14th because we thought Tuesday would be a lot easier than a Sunday to launch a new workflow on the inpatient unit. And we already did a pilot on one of the units, and we got positive feedback about the workflow. And again, there will be more information in the e-learning about how to complete the safety checks, but this is just a quick screenshot of how it looks on the Rover app on the phone. All right, so now I'm going to move into the big advantages. So those really come in our dashboards and reporting functionality. We're really going to be able to run much better reports than we are now on things that it might be a bit hard to believe are difficult to get out of the record in terms of data. But something as simple as the number of patients who are currently enrolled in all of our services, that can be a difficult number to pull at the moment. And so we will have a much clearer picture of this, again, across all of our services with the module. And with that, if we know our pool of patients better, we can pull other things much quicker, like diagnoses, length of stay, all that other information that I know a lot of us are very excited about. Things like how many appointments has a patient had while they've been in an episode of care. Again, that's something that you would think would be pretty easy, but that has not been the case. The big thing in terms of treatment plans is being able to quickly identify which patients are missing an active treatment plan or which have a lapsed plan. Again, most of that is done with manual auditing at this point, but I'll show you on the dashboard how it's going to look to be able to see that very quickly. And then it's going to be a lot easier for staff on both inpatient units and CPAP to see who is actively enrolled in ambulatory services. I know that can be a bit tricky to find in the chart as well. So hopefully that'll be much more clear. So this is an example of a dashboard. So the 2 main dashboards that are coming with the module are the provider clinician dashboard and then a clinic manager dashboard. I'm showing the clinician provider dashboard because that's going to be the one that the majority of people watching today are going to see. And you can see in the upper left-hand corner There's a section that says my treatment plan's coming due, upcoming or overdue, and it comes in 3 sections. So that's going to be really helpful to alert you to any treatment plans that are coming up. And then I also want to highlight the top right corner that gives you any treatment plans that might be still in the draft phase that you need to finish, or again, some that are lapsed. And then there will also be additional information that we're going to add in here. And some of these components of the dashboard might be some that if you use dashboards, you are already familiar with. So this is a close-up of that top left corner of how it would look if a treatment plan is coming due. And you can see that it tells you whether it's due in 3 days or 4 to 10 days. So it gives you a nice heads up. And again, this will be across settings, but you can see that this is just in one department that I'm logged into. So it's linked to my profile as well as the department that I'm logged into. And if you select the magnifying glass, you can see the bottom, which links to the report that feeds the dashboard. And that's where I get more specific information about which specific patient has a treatment plan that's coming up. So one, I think, general piece of information that's helpful to know about eRecord is that whenever you see a pretty dashboard like this, there are reports behind the scene that are feeding it on an active basis. So there will be some reports that we do put into dashboard form, but there will be a lot more reports that just exist as reports that might not feed into a dashboard. So that's kind of, if you're interested in more reporting pieces in the future, that's one helpful way to think about it. All right, so in terms of support that will be available once we go live on the 12th, each clinical area has super users who will receive additional training prior to go live. And the number of super users depends on the clinical area, how big it is, how complex it is in regards to the changes that are happening. The super users will be especially important to help understand specific clinical workflows. So a lot of those pieces that I was mentioning in terms of what do you put when there's a wild card in that discharge criteria note? That would be a great question for your specific clinical super user. And clinic leaders will be giving more information as we get closer about who those super users are and how to get in touch with them. As always, you will be able to call or email the help desk. But another feature that will be available, at least for the first week after we go live, is F1 in eRecord. So some of you might have used this in the past, and normally it just pulls up like a chat or a search function where you can type something in and get some answers for it. But during go live week, there's what's called a splash screen, and you would enter some information about yourself, and then it automatically links you with a trainer via video. So that can be really helpful to show you step by step and really walk you through any question that you might have. All right, so I talked about, my role in the module, but there have been lots and lots of people who have helped me, and I, have a few up here that I wanted to make sure to name. Definitely, I want to shout out for my inpatient partners, because that is a world that I really don't know very well, and so I heavily relied on them for a lot of information, and then also my ISD build team. And really everyone on this list who has just been very responsive for my emails and given me a lot of helpful information. Oh, and I'm 30 seconds early, but we can now take some questions.
Thank you. Anybody in the audience with any questions for Dr. Hunt? Oh, there you go. Oh.
Thank you. Thank you, Kayla. This just looks like a tremendous amount of effort. I'm going to start my question by owning the fact that I'm a late adapter of technology always. This looks like a lot of clicks to me to get a treatment plan up and going. What are the advantages of this transition, and how can I wrap my mind around being a maybe earlier adapter?
So the biggest advantage is definitely on the reporting end. So one of the hardest things about the way that we document most things in psychiatry is that we use a lot of free text, which is really, really hard to pull out of the chart. So I think with this move, ultimately, once people get more comfortable with the change, we're hoping that it feels approximately about the same amount of work as it is now, but we'll have huge reporting capabilities in order to see more information quickly about the patients that we're serving.
Hi, Kayla. Thank you so much for this. This was helpful. I have a question about the group documentation. I run a number of trauma groups in HEAL, and one of the things we don't currently do is put in the line from the treatment plan. And I'm a little concerned about that because if I have a group of 8 to 10 people, I now need to hunt and peck through their treatment plan to figure out what objective goes in that spot. Is there a way to make that easier or more streamlined, or do I now take a note of each patient and what line it is?
Is that Kate?
It is.
Okay. Hi, Kate. We've emailed a lot, but never met in person. So that was the what older adult had specifically chosen to put in their group level note and individual level note. So I believe we communicated about what to put in for HEAL. So that would look different. That's one piece that would look different for you. And the last thing, not last thing, but one thing that I'll say is that obviously we have done a huge amount of work. Thank you, Tara, for recognizing that, to prep for this as best we could. But we know that there are going to be changes that need to happen after we go live. And there will definitely be an opportunity once we settle a little bit to make some changes, continue to optimize, and really think of this as like a living, breathing thing that we're working on to make it better.
Hi, you just sort of like proactively answered my next thought, because I have a good sense of this, wasn't sure about the group, about what are the opportunities as we sort of get more user interface to kind of do next level of like optimizations, improvements. And I'm thinking especially about across the continuum, because I know the module works with like the ambulatory pieces over here, the CPEP pieces over here, the inpatient piece over here. So more interoperability. Yeah, that's the word. Thanks.
Yes. And you'll see Helen was on my acknowledgement list because she has been super integral into this project as well from a compliance standpoint. So the functionality that comes with the module is a lot, but there's also a lot that Epic has that we're just not using. Mostly because historically we haven't had a lot of knowledge within the department about all of those options. And that's, I think, part of my role in informatics and as a clinician builder to know more about that and help us figure out how we can implement what's already available. As is tough, it always comes with change. So I think that's going to be the difficult part, is figuring out if it's worth the change given the advantages that will come with it. But there are different note types, different ways to put in the biggest thing is to put in the data from the start in a way that's more capturable.
We have a question in the Q&A box from Dr. Heatley. Can you talk a bit about how this might be a tool for clinical research and program evaluation? It seems like the potential is great.
Yes, definitely. And so another kind of endeavor that we're trying to create within the department is a more clear structure for researchers, for clinicians, in terms of how to request to get this data out of e-record, because we know that in and of itself can be challenging. And so we're in the process of both building a team of people who can help with that, and then also figuring out a workflow of how that is going to work, to figure out how we can both partner in the beginnings of projects to plan for getting data out, and then also maybe working on the back end for QI projects with folks that are more clinically focused. So we definitely have lots of plans and lots of ideas of how to build that up within the department.
Hi. Just a quick follow-up question about the inpatient group documentation. So I noticed here you had to link it to a primary presenting problem or diagnosis. Are we anticipating that for it? Okay, great.
No, so that's primarily for charge capture. We have to do that to drop a charge, but on inpatient, you're not dropping charges at that level. So you wouldn't need to do that.
If we do start dropping charges, then we would need to incorporate that?
Yes, because there always needs to be a diagnosis linked with a charge.
Thank you.
Hi, I represent Interpreter Services. So if this is for standardizing information reporting and the patients that we serve, optimizing services to them, how could this be optimized for our patients with LEP?
What was the last part?
Our patients with limited English proficiency? And especially since we also have to document for Joint Commission. And New York State also has laws that include, at least in your region, including your top 5 languages.
Mm-hmm. And I think the piece with the module is that there's not much that the patient is going to see different. Like there's not any changes coming with my chart. There are kind of related projects, like we're moving toward the standardized Stanley Brown safety plan within Epic, which has a Spanish version. And so we're looking to roll out as many options as we can in languages other than English. I think that is a huge area for growth. And definitely, when we're looking at adding different standardized measures, adding those in different languages, and providing, I think, I know even one thing that's tough working in pediatrics is if you don't label if the parents don't speak English, but the child speak English, like how do you label that to make sure they get the appropriate interpreter services that they need, but then we're maybe not having as clean of data. So I know there are definitely a lot of areas for growth related to that, but not as much with the module, unfortunately.
So thank you, Kayla, for the wonderful presentation. From the administrative and I know this is going to be great. But at the personal level, as a clinician, I know this is going to be a rough landing for me because recently I upgraded my cell phone from iPhone 7 to 13, and I'm still trying to figure out what's going on. And this thing seems like an even bigger transition. And whenever I have these kind of issues in CPAP or in inpatient unit or wherever, I always turn to the residents, who tend to do far better. Are there any roles, potential for QI, for optimization, or something that the residents also can have a role in this process?
That's a really good point. I hadn't, I think my interfacing with trainees is often they've got a lot on their plates. So I think it can be tough to kind of put something else on, but I do think we have, so the super users are all different types of clinicians and providers, depending on the unit or in the clinic. So I think they're really going to be the primary people to go to if you need someone at your elbow in CPAP, because this is the first time that you're doing it. Yeah, I think it could be interesting to think about more residents, especially if they're going to be here, multiple years with us, and how they could maybe take some things on the further along they get.
And then we have 2 questions within the Q&A box. One is, are there ways to include patient-centered language and goals with new treatment plans? This has been emphasized for us when completing these.
Mm-hmm. So yeah, the nice thing about you saw that I selected goals that were mostly pre-filled, and then in every care plan, there's also just a complete wildcard that you can totally enter in anything that you want, and you can also edit anything that comes in. So I think that's a huge advantage, to be able to put anything in patient-centered language in terms of goals or interventions that are being used. So I think it is very pre-form in a lot of ways, which will hopefully be helpful for clinicians, but then there's still a lot of customizability depending on the patient.
And I think that gets to the next one. For treatment plans, will there be free text options for clinical areas that are required to use patient words and quotes for treatment plans instead of the pre-populated list that was demonstrated?
Absolutely, absolutely. And I think the care plans is definitely a place where we'll see a lot of optimization after we go live. And I want to encourage people to think about that, to make it more applicable to their clinical areas, because again, there's just a lot of flexibility we have with that. And we went with what we thought would work best at the start, but are very, very open to changing those if people find that it would be helpful.
Great. Any last minute questions?
Great presentation, Kayla. Thank you.
Thank you.
I just wanted to clarify that the customization with the treatment planning that you mentioned, that we can actually customize that by clinics or clinical areas.
Yeah. Thank you.
Thank you so much, Kayla. It's a wonderful presentation, a lot to be presented. I know it was a quick overview and summary, but very helpful. And again, service-specific areas will have more information for all of you, and especially in the next couple of weeks, more online training to get you prepared. But again, thank you all for joining us, and if any additional questions, feel free to let us know and your service leadership know. Thank you.
Thank you.